You're listening to Medscape's In Discussion series on myelofibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Tania Jain. Dr. Jain is an associate professor of oncology at the Johns Hopkins University School of Medicine, where myeloproliferative neoplasms are the focus of her research. She is also the director of the Adult CAR T-cell therapy program for hematological malignancies at the Sidney Kimmel Comprehensive Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Welcome, everyone. We are in our season 2 of Myelofibrosis for Medscape in Discussion podcast. I'm your host, Tania Jain. We are here in our episode number 3 to talk about primary myelofibrosis and post-ET and post-PV myelofibrosis. Today, we have the pleasure to chat with Dr. Brandi Reeves, who is a hematologist oncologist and assistant professor of medicine at UNC Chapel Hill, where she is a very prolific physician scientist and specializes in the treatment of MDS, MPNs, and bone marrow failures. Welcome to the podcast, Dr. Reeves.
Thank you so much for having me, Dr. Jain.
Wonderful. So we want to talk to you a little bit about how we should think differently, when we're thinking about primary myelofibrosis versus post-ET or post-polycythemia vera myelofibrosis. What I want to get started with is prevention first, right? So we've seen the emergence in terms of the body of data for interferons and using them in the context of early MPNs, ET, PV, and maybe even prefibrotic MF. So how do you strategize when you see a patient with ET, PV, or how do you think about their treatment options in terms of, can I delay MF? Can I prevent or at least delay the progression or evolution to MF?
What I've always found interesting as a physician that treats really exclusively MPNs is that the goal of therapy for physicians over the last few decades has really been to prevent thrombotic complications, especially in PV and ET, and also to improve symptoms. But there really wasn't a whole lot we were doing in terms of preventing progression to MF or post-PV, ET, acute leukemia. What's been exciting over the last, 5 to 10 years has been the growing body of evidence with interferon alpha therapy for these diseases that really looks like it has an impact on preventing the progression to MF and then post MF AML. What's so fascinating to me about this is that patients have been very concerned about that the entire time. Our discussion in clinic with patients has really then just kind of avoided this until now. And now we have therapies that are potentially disease modifying and impacting this clinical course. When I see a patient in clinic with ET or PV, I'm thinking, again, not only about thrombosis and symptoms, I'm thinking about their long-term trajectory. Roughly 1% per year is the rate of transformation to myelofibrosis and about 0.5% or so transformation to acute myeloid leukemia. When I have a patient, especially a patient who's under the age of 70, and I, expect that they have a 15 plus year anticipated overall survival, I'm really thinking about therapies that might have an impact, not just on thrombosis and symptoms, but also on the long-term disease progression. And there is where I'm thinking about treatments like interferon alpha currently.
Makes sense. Makes a lot of sense. And I think in our practice, interferon alpha or versions of it with Pegasus or Ropeg interferon, they've certainly, I heard someone use the phrase, I'm using it like water now. So I think that's certainly happening, that the use is growing more and more just as the data has emerged. Tell me something, how do you think about it, or if at all, do you think about it differently in the context of the driver mutation, JAK2 versus MPL versus CALR? What is your interpretation of the data mostly focusing on JAK2 here?
The bulk of the data for interferon alpha improving outcomes comes from the polycythemia vera world with the randomized controlled clinical trial of Ropeg interferon versus hydroxyurea in higher risk PV patients. So all of those patients are going to have a JAK2 V617F mutation. But we also know that pegylated interferon alpha, first generation of pegylation for interferon alpha, has been used in ET, and in that situation, right? So roughly 50% will have a JAK2 mutation, about 30% will have a calreticulin mutation, and a handful will have a MPL mutation. Certainly the data are fairly robust, or becoming robust, for JAK2 mutant disease, where reduction in mutant allele burden really seems to be correlated, at least with composite outcomes of myelofibrosis-free survival, overall survival, and thrombotic complications. The data is a little less clear for the other mutations, in part because MPL is just so underrepresented. But then calreticulin, right, the data is here and there. There seems to be less of a robust molecular response with calreticulin mutant disease. Yet the clinical outcomes, so the hematologic parameters, seem to have similar responses. And especially when we look at retrospective data, like from the AYA populations who have mostly ET and it's largely calreticulin mutant, they seem to have better long-term myelofibrosis-free survival if they were on interferon as their upfront therapy versus anything else. So while that's not super robust upfront data in the calreticulin setting, I think it's all pointing to interferon as likely beneficial, maybe not as beneficial as it would be in the JAK2 mutant situation, but it's something I would consider for all of the patients as disease-modifying therapy if they otherwise qualify.
Makes sense. Let's move into the space of someone actually now has full-blown myelofibrosis emerging from a prior PV or ET, or even pre-fibrotic, something that's closely into myelofibrosis. What is your approach with interferons there? Are you commonly using that, since that is, I feel, where the data is not as robust, developing, but not yet available to read?
We are not using it super commonly in that setting. And I will say for a number of reasons. So, oftentimes there's already cytopenias present. So, adding interferon on top of that can be tough. It depends on who your patient is. Many of the patients that we're seeing are also older. And of course, as a tertiary referral center, a lot of them are higher risk. So, we're thinking about sending them to transplant, and you don't want interferon on board for transplant. I think it's interesting in terms of positioning it. I'm not clear that as a single agent, that would be a be all end all, but the combinations with things like JAK inhibitors are super enticing in terms of symptom prevention or symptom control, maybe getting at the clonal evolution a little bit better than either agent alone. Not clear, right? Super early data. But I think it's really hard to use it in the myelofibrosis setting, especially if the myelofibrosis is a little more advanced. So we don't tend to use it a whole lot.
Makes sense. So share with us a little bit, how is your approach in terms of evaluating, I guess, risk stratifying, and also for treatment in primary myelofibrosis versus post ET or post PV myelofibrosis?
We make such a big deal about primary versus secondary myelofibrosis, and we know that they're somewhat different, right? So primary myelofibrosis means it's de novo, you didn't have a pre-existing ET or PV, and secondary means you had one of those diseases and then you've progressed. We know that there are some slight characteristics that are different between those groups. The post PV, post ET MF tend to have better cell counts, right? They're not as cytopenic. They tend to be older. The JAK2 variant allele frequency tends to be higher because this is a disease that's been there for a long time. Yet we consider them very similarly when we're treating, which I think is interesting. We know the molecular landscape is a bit different. There tends to be more mutations in primary versus secondary myelofibrosis, at least in the mutations that we've looked at so far. When considering treating them, though, I've kind of taken a very similar approach to, well, the end game is this is myelofibrosis. Usually they're symptomatic. There's usually splenomegaly. And so, right, my goals are to reduce the spleen size, improve the symptoms. We might have slightly different challenges when we're treating the patients, including the cytopenias, especially in the primary myelofibrosis patients. And when I think about risk stratification, the MySick PM was specifically designed for the post PV, post ET myelofibrosis, but it doesn't incorporate the karyotypic and molecular data that we know are super important in primary myelofibrosis, at least. and likely in secondary myelofibrosis. There was a paper looking at the DIPS plus in comparison to MySec PM, and more recently, the MIP70 version 2 versus MySec. And in both of those cases, it looked like those two, with the addition of karyotypic and then molecular features, outperformed the MySec PM, but they're not robustly used. So I tend, in my practice, quite frankly, to use all of the scoring systems and see what comes out the worst and what feature is it that's driving that, and have a conversation with patients about what we found. For instance, the ASXL1 mutations in secondary MF may not have prognostic significance, right? So I'm curious to hear how you are using those scoring systems, especially from the transplant side of things.
Yeah, so I was going to say that the biggest place where I do use the scoring systems is mostly to make a transplant decision. I think treating the patient in front of you, as you alluded to, is treating what needs to be treated in an individual patient. If it's spleen symptoms, JAK inhibitors, regardless of their risk stratification. If it's cytopenias, then whatever little we have at hand for cytopenias, regardless of the risk stratification. I can't remember the last time I used MySec PM. I think it just never caught practice. I do commonly use DIPS plus MIPSS, more so for, I guess, standardization, right? If a student is going to do a retrospective review or something like that, it's a valid way to stratify and standardize your patients. I think we have to agree. So I put in my note for that, but really what I use it for is understanding what really matters, right? I think what these scores have told us, even though they include age and do not include spleen, which, some of these are not modifiable factors, but what these scores have taught us is that anemia matters, right? When you're transfusion dependent, we're looking at a shorter progression-free survival. High risk mutations, and I think data there keeps evolving as well, rightly so. Also, I think make a big impact in terms of how quickly this is going to evolve or not. So that is kind of how I have evolved. And I'm sure we'll all continue to evolve as we learn more about these, because right now we're looking at single mutations. We haven't even started looking at combination mutations, right? I mean, that era is just starting because, as you pointed out, ASXL1 by itself, for example, in secondary MF or post-ET, post-PV MF, may not have as much relevance as a new ASXL1 emerging 2 years into a primary MF with cytopenias. There is data that hopefully be coming out soon where it seems like ASXL1 by itself does not have a major impact at all unless it's combined with either EZH2 or SRSF2 or other mutations. These tools are good guidance tools in clinic, but I think we all use our clinical context from them to make actual decisions.
Yeah, absolutely. And if you were considering a secondary MF for transplant, would you accept a MIP score, for instance, versus the MySic PM score, which is where it was validated, right?
Yeah, so I guess maybe by theory I should do my sec PMs, but but in reality end up doing MIP70 or DIPS plus. DIPS plus mostly for records because I do want to incorporate the molecular data. So eventually it is the MIP70 that ends up getting used the most, primary or post CTPV.
And are you including ASXL1 mutations?
Usually, yes. There is an element of chronicity here, right? I mean, I'm sure you do too. I have a couple of patients who've had ASXL1 and things have been similar, not great, but similar for like over 4 years. And we're watching it and, haven't needed to intervene yet. Whereas I think someone who comes in with ASXL1 de novo plus JAK2 or whatever, that tends to play a slightly different clinical course and usually have needed to intervene more quickly.
Yeah.
The one thing that I struggle with and kind of clinically distinguishes primary versus post ETPV MF patients in clinic for me has been their prior thrombotic history, which usually you'll see if someone's had PV for a while or ET for a while and they had a bad abdominal clot in that earlier time frame and now have liver decompensation or other organ issues as a result of that clot. How prominent do you think is that in your clinic?
Is the setting of the number of thrombotic events?
For example, I have a small cohort of patients who had a consequential splanchnic vein thrombosis or some abdominal vessel thrombosis early in their course of their usually PV,
Yeah.
and have developed portal hypertension as a result, one even liver cirrhosis now, and now they have myelofibrosis, which needs more intensive interventions. A few challenges there. One, splenomegaly, which can happen from MF as well as from their portal hypertension, and no easy way to distinguish. Two, I feel like their organ dysfunction gets in the way of us doing as aggressive treatment options as you may be able to do in a primary MF patient where the liver was fine up until now, or still is. And obviously, most importantly, transplant consideration becomes a major challenge in someone with esophageal varices or spleen that is not responding and so forth. So I'm wondering if you have that set of patients and how do you manage that?
We absolutely do. It's probably about 5% of our patients. And it's curious because that cohort of patients that I have, it was the splanchnic vein thrombosis that heralded the presence of their disease. They tend to be younger patients, tend to be female, although, right, there are still males with this. And sometimes this is a chronic finding. It's not even the acute event. They just had yellow eyes and they went to have labs checked. And then subsequent workup showed that they had hepatomegaly, cirrhosis, then ultimately found to have a JAK2 mutation. And often, right, they have normal cell counts. And this is like an MPN, unclassifiable at the time that you pick them up. It is really curious to me because they're, in the ones that we get acutely, there's a lot of different things going on because usually the liver disease can be pretty significant. You're hoping that they don't need to go to transplant. And then if they do go to transplant, right, they're going to be on immunosuppressants afterwards, which is a whole other ballgame. You're thinking about other cytoreductive therapies if they need that versus the patients that come in with kind of these cryptic events that present much later after the complications of the thrombotic event happen. So the cirrhotic like phenotype with the varices. And so in those patients that present asymptomatically, they were incidentally found, often they're really asymptomatic. It's tough to know, right? They've already got cavernous transformation. What am I supposed to be doing here? Usually their platelet counts are on the lower side. It's not clear what to do. Many of those patients that I've seen over the years actually do quite well. Most of them are still in chronic phase disease. We have a few who have progressed with molecular changes where we are considering transplant, which then, as you know, becomes challenging because of their big spleens and their liver disease and whatnot. And then this whole idea of do they need a visceral organ transplant, not just a liver transplant if something goes down. I handle those who present acutely with their thrombotic event slightly differently because those patients I'm going to put on anticoagulation. Depending on how they present, I might be putting them on cytoreductive therapy as well. And they're going to have a slightly different clinical course from what I've seen versus those that present incidentally with these already chronic clots. In those cases, I don't even know if I should put them on anticoagulation, right? So their disease appears to be stable. There's something different where it caused, not a massive event when they presented. But I have no idea how to optimize these patients for transplant, I must confess. So if for any of these patients who have had the abdominal vein thromboses, I try JAK inhibitors, and I'm not sure what your success rate is here in this setting, but it seems to maybe shrink the spleen a little bit, but not hugely. And they're the ones I really worry about complications post-transplant.
I totally agree. I think out of my cohort of now 10 or 11 of these patients, I have one patient who had a response to Jakafi 25 twice a day, which is something that I rarely do. And that is an N of 1 where I saw the spleen improve a tad with JAK inhibitors. But outside of that, I've had patients run through all JAK inhibitors and no response to the spleen. We've deliberated removing the spleen. This is after extensive discussions with hepatology, right? I mean, if you think that this is coming more from portal hypertension, removing the spleen could be potentially less consequential. I'm not sure. I'm not sure I agree with that based on what I've seen so far, although done very, very infrequently, because it's probably not true that MPN is not involved in the splenomegaly. I think it's both. And whenever at least I have tried to touch that MPN spleen, it has been a very rocky course. I don't know if your experience is different with removing spleens, but it has certainly not been my go-to strategy for that reason.
Yeah, and I will say in those who've already had an abdominal clot, we know that the post-splenectomy thrombosis rates are high. It just depends, right, where the clot happens and how significant it is. But if you've already got liver disease pre-existing, it makes me very nervous to predispose a patient to more abdominal clots where you might then necessitate organ transplant and preclude them from getting their stem cell transplant, which was the whole goal of the spleen removal in the first place. So I agree with you. And I will confess, I have irradiated one spleen. I saw no response in this setting. There's probably some MPN disease there, but it's slightly different when you have this back pressure from the portal hypertension and your response to radiation. I haven't tried splenic embolization for these folks again because I've been concerned about the liver, but I will say that's another approach that could be tried. I don't know that there's a great set of data on outcomes in partial splenic embolization in those who've had prior abdominal vein thrombosis, though.
Completely agree. We've done that in the context of removing the spleen. I don't think we've tried the embolization by itself as an end goal treatment. But yeah, exciting. It seems like we may be able to even put our cohorts together and actually make a meaningful descriptive something to share with the group, because I struggle with these scenarios who come in with thrombosis and abdominal thrombosis and impact to the liver, and we're now in a more advanced MPN phase where more aggressive stuff ought to be thought about.
Yeah, absolutely.
Wonderful. Well, I had fun. We shared some very exciting things and maybe even future ideas to think about, talking about our primary versus post-ET and post-PV myelofibrosis. Well, I'm going to thank you, Dr. Reeves, for taking the time. It was a great learning experience for me, and I'm sure the audience feels the same way. And we'll see everyone back with our next episode.
Thanks for listening to Medscape's In Discussion Myelofibrosis podcast series with our host, Dr. Tania Jain. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on myelofibrosis.